call upon Sweta Singh. She will be presenting an ISA or the windows to the soul, chronic CSR as the presentation of pituitary tumor.
Good afternoon, everyone. My topic for today's is eyes are the window to the soul. So this is a case of a 50-year-old female who presented to us with gradual progressive diminution of vision in both eyes for the past 5 years. She had associated metamorphopsia. She was fairly controlled diabetic and hypertensive and was diagnosed as bilateral CSCR elsewhere. There was history of use of topical NSAIDs, dorzolamide and tablet eplerenone. The history of focal argon laser was done twice elsewhere. There was no history of any corticosteroid use, so they labeled it as therapy-resistant chronic CSR. On anterior segment examination, the best corrective visual acuity was 6/12 in both the eyes, and rest of the anterior segment was within normal limits. But in posterior segment, the fundus of right eye showed significant RPE changes at the posterior pole, along with some mild to moderate changes of diabetic retinopathy. In left eye, the media was quite hazy due to asteroid hyalosis, but we could still detect some RPE changes at the posterior pole itself. OCT showed in both eyes shallow SRF, which was suggestive of chronic CSR, along with loss of ISOS junction. On OCTA, we could not detect any choroidal neovascular membrane in either of the eyes. On FFE, we could detect some window defects, which were a sign of previous focal laser done. Ink blot pattern was also seen very close to fovea, which was not laserable. That was in the same, that same thing was also detected in the left eye. Now, typically, a CSR presents as a unilateral condition in young middle-aged males, and it is self-resolving. But CSR in an old-age female, bilateral presentation, and recalcitrant was something different, and we were sure that we were missing something. So we went retrospectively and analyzed her history. She had easy fatigability and mood swings, truncal obesity, thinning of upper limbs, rounding of faces, and she had a peculiar history of growth of unwanted dark hairs on face and trunk, for which she had even underwent laser hair removal twice in past. She suffered multiple fractures in past few years. So we came to the conclusion that there was some hormonal dysfunction, and we advised for an endocrinologist review. From our side, we gave topical NSAIDs and lubricating eye drops. So for the first time, she underwent a biochemical evaluation and was diagnosed of ACTH-dependent Cushing syndrome, and pituitary was seen as a source, which was detected on the gold standard inferior petrosal sinus sampling. All was done under endocrinologist. MRI pituitary dynamic contrast also revealed a small pituitary tissue. So, with a neurosurgery opinion, she underwent exploration of the sella, and a pituitary tumor was resected. It was identified as microadenoma, and the next day itself, her cortisol levels dropped from 35 to around 3, which was quite significant. After 1 month of follow-up, we could see that there was complete resolution of SRF, and vision acuity improved from 6/12 to 6/9. Although there was some RP degenerative changes and ISOS junction loss, which contributed to decreased vision. The same was detected in the left eye also. Patient has been on regular follow-up for the past 1 year. Her vision improved and metamorphopsia has significantly reduced. She consults with endocrinologist and neurosurgeon regularly. There was no recurrence of CSR reported during this period, and there was no recurrence of any of the pituitary tumor. Now, hypercortisolism is a known risk factor for chronic CSR. Patients with chronic CSR had a higher odds of Cushing syndrome than exposure to exogenous steroids. The blood cortisol excess, this leads to vasospasm in the choroidal vasculature, which leads to choroidal ischemia and hyperpermeability, which in the end leads to the deposition or accumulation of SRF in the, between the neurosensory retina and the RP. It is a multifactorial disease, and localized serous retinal detachment at macula is the characteristic. We can see focal PEDs, and typically affects middle-aged men, although women can also be affected. Acute CSR has been categorized as spontaneous resolution within 4 months, but chronic is termed whenever it persists for more than 4 months. It carries a guarded visual prognosis due to atrophy of photoreceptors and RP. Associated risk factors include the triple S, that is stress, steroids, and smoking. So one should advise and advocate against it. And currently, this has been categorized under pachychoroid spectrum, in which there is hyperpermeability of the choroid. Management currently involves observation, lifestyle modification. We, in our patient, have checked on steroids. So that was a major management in our case. So there have been published literature which has shown an association, a positive association
Time
between
is up.
Cushing syndrome and
Time is up.
sorry sir, just last thing. Okay, so this is one of the study which I would like to discuss, in which they have analyzed a large cohort of CSR patients, around 35, and they showed that none of them had any Cushing syndrome phenotypes. So they have advised against screening of Cushing syndrome in CSR patients. So take home message that it is a clinical diagnosis, lifestyle modification is the key. Not every patient of CSR needs to be screened for Cushing, and patients of Cushing need an ophthalmological workup only if the ophthalmic symptoms arise. Also, in cases of atypical presentation, think out of the box. Thank you.
So that was really interesting, and I think I must say congratulations to you for picking up this pituitary tumor just from the CSCR. One thing I would like to ask you is, how long did this patient use eplerenone, and why do you think that patient did not respond to eplerenone? Because eplerenone is a mineralocorticoid antagonist. Patient has some inherent cortisol, high cortisol. The eplerenone should have, counteracted that. So why do you think it did not work?
Ma'am, because due to her continuous hypercortisolism, because of high cortisol levels in the blood, which remain for a longer period of time, there was dysfunction at the RP level, and there were continuous hyperpermeability at the choroid level. So even eplerenone was not that effective. Also, one should not keep a patient on eplerenone for a long time, because it can lead to fluctuations and decrease in blood pressure. So we had to maintain blood pressure and the kidney profile of the patient also. So that's why.
How long was that eplerenone given?
Ma'am, when patient presented to us, she was on eplerenone for a month, but she was not showing much resolution of SRF. So looking at the phenotype of the patient, we advised for an endocrine evaluation.
I think another thing would be the time, the diurnal variation of the cortisol, because the cortisol is secreted highest in the morning. So when this eplerenone is given, at what time the patient took eplerenone also would be effective. I mean, would be of importance in this case.
Okay, ma'am, we'll take care. Thank you.
Excuse me. How did you suspect pituitary tumor in these patients, in your patients?
Sir, just she was showing to us multiple times. She was coming to us in regular follow-ups. And
Can you turn on the mic, the other mic? That was not working.
Hello?
Yeah.
Okay. So she was on a regular follow-up, and just after looking at the patient, she had round faces, she was always depressed, she was even taking some medication, she was on and off medication of depression. So just looking at the history of the patient, we gave a chance of evaluating for endocrine, and it was a good decision from our side also, that for the first time she underwent.
What evaluation was done endocrine?
What evaluation was done?
Yeah.
Serum cortisol levels were done, and the high dose dexamethasone suppression test was done. We had for detecting whether it was adrenal source or pituitary source.
So clinically you didn't suspect. Only after seeing cortisol you sent for a neurological evaluation.
Yes, we did the basic from our side and then sent for an.
And your study, you said proposed pachychoroid spectrum.
Yes.
Did you analyze the choroidal thickness in your cases?
No, sir. We had the OCD but not the EDI, so we couldn't actually.
No, whenever you are talking about it,
Thank
it's
you,
better to include in your study before talking.
Okay, sir. Will be taken next time. Thank you.
Thank you very much.
Pigmented? Was the patient having hyperpigmentation?
Easy bruising, yes.
Not easy bruising, hyperpigmentation.
Of the skin.
Of the skin?
Yes. That's around the neck, and
Yeah.
she had those changes.
That is a clinical indicator that ACTH level is high
Okay, sir.
in the flexures
fractures,
hyperpigmentation.
multiple
Yeah.
fractures, and different other cortisol phenotypes.
That you have not presented in the cases.
Sorry, sir?
That you have not presented in your presentation. So everything we cannot take it as
Okay.
right. Okay. Thank you.